اللي حصل. وهنبدأ إن شاء الله الشيست ايميجينج سيشن. يشرفني طبعا أستاذي ويعني والغني عن التعريف أستاذنا الدكتور عماد شنودة، سكرتير الجمعية المصرية للإشاعة. ويعني ما أعتقدش إن ما فيش حد في الإشاعة في مصر ما يعرفش الدكتور عماد.
خليك جنب دلوقتي لما اوكي.
مساء الخير يا جماعه، ميرسي جدا. انا بشكر اخواتي واصدقائي واساتذتي برضو واولادي وكل الناس بتوع جامعه عين شمس. انا يعني كل سنه بأسعد ان اكون في وسط الناس الجميله دي، وربنا دايما يعني يديم المحبه بيننا جميعا. The first presentation will be Dr. Rania Refaat, Professor of Radiology at Shams University, and Rania will be speaking about unknown cases, the ultimate challenge.
Assalamu alaikum. I'd like to thank our chairpersons and the organizing committee of our conference, as well as the whole radiology department members, especially Professor Dr. Muhammad Aboulouda, who is the one who established the idea of the annual conference since being the head of our department. I'm going to present some unknown cases, the ultimate challenge. I am Rania Refaat, Professor of Radiology in the Department of Diagnostic Radiology, Intervention and Molecular Imaging. 22-year-old male patient presented with cough and fever. Here we can see the mediastinal window of some selected images, in long window setting. This is the mediastinal setting of the same images. The diagnosis was pneumomediastinum with subcutaneous emphysema of the anterior and both chest neck regions, with bilateral patchy areas of ground glossing. The patient was clinically suspected to have COVID, so it was correct 4. After exclusion of esophageal tracheobronchial causes of pneumomediastinum, our diagnosis was established to be spontaneous pneumomediastinum with a surgical emphysema as the result of vigorous exercise. This is called Hamann syndrome or Macklin syndrome. Hamann or Macklin syndrome is most commonly asymptomatic, but sometimes presents with non-specific chest pain, dyspnea, dysphonia, subfebrile temperature. The Macklin effect due to the alveolar rupture and interstitial emphysema tracking into the mediastinum along the bronchovascular interstitium. Interestingly, the clinical examination may demonstrate Hamann sign as we see some air surrounding the great vessels as well as the heart. This is caused by synchronous rasping sound due to pneumopericardium. The clinical course is usually benign and self-limiting, and management is conservative, and this was done in this patient. A 58-year-old female patient coming with cough and fever of 4 months duration. Here we can see the lung window setting of also some selected images of significance. This is the mediastinal window setting of some selected images. Our diagnosis was multiple pulmonary nodules, as we saw, scattered, having fissural and subpleural location, multiple enlarged lymph nodes at both hilar as well as mediastinal lymph node in the pretracheal and prevascular aortic space. The right hilar lymph node attenuates the right upper lobe bronchus and the bronchus intermedius with few ill-defined and faint ground glossing at the right upper lobe as well as the right middle lobe. The mediastinal and the hilar lymphadenopathy with scattered subpleural and fissural pulmonary nodules, as well as the mottled bone appearance highly suggest sarcoidosis, yet lymphoma is to be excluded. Sarcoidosis is non-caseating granulomatous multisystem disease, has many manifestations, including pulmonary and mediastinal manifestation, as well as the cardiac, musculoskeletal, CNS, abdominal, and cutaneous manifestation. Most commonly presents between second through the fourth decade of life. However, diagnosis in children and elderly also recognized. Pulmonary and mediastinal involvement occurs in 90%. Clinical presentation variable. It's diagnosed by combination of clinical as well as radiological features. Regarding the chest imaging, symmetrical hilar and mediastinal lymphadenopathy is one of the characteristics, as well as the perilymphatic nodules. Sometimes we notice pleural effusion. The perilymphatic, whether central or peripheral, central along the bronchovascular bundles, peripheral having subpleural and fissural distribution. The 1, 2, 3 sign is highly pathognomonic for sarcoidosis. It includes right paratracheal, right hilar, as well as left hilar lymph nodes. The nodes can be very large. However, it tend not to abut the cardiac silhouette. This is the differentiating point with lymphoma. Calcification occurs after treatment, and the characteristic is eggshell calcification. Stages, 5 stages. Stage 0, there is nothing seen. Stage 1, hilar and mediastinal lymph nodes only. Stage 2, lung and nodal. Stage 3, parenchymal, and the end stage is stage 4, which is pulmonary fibrosis. The pattern of the bone affection is less like reticular pattern. A 53-year-old male patient with shortness of breath. Here we can see some images of the lung window setting. Some coronal reconstructed images, also in lung setting. Some mediastinal axial cuts. The lung was moderately hyperinflated, more on the right side, with thickened interlobar fissures, subpleural honeycombing, innumerable variable size emphysematous pulli, intermingled with areas of fibrosis, amalgamated to form conglomerate masses of fibrosis at both upper lobes with subsequent tractional bronchiectatic changes. So the diagnosis was usual interstitial pneumonia on top of chronic obstructive pulmonary disease and emphysema, complicated with cor pulmonale. The ventricles were, both ventricles were prominent. Typical features include reticular opacities in subpleural lung with characteristic honeycombing and tractional bronchiectatic changes, having peripheral and lower lobe predominance. This is the main differentiating point with non-specific interstitial pneumonia. The reticular pattern to ground glossing are 1 or greater. The honeycombing again is highly specific for usual interstitial pneumonia. Usual interstitial pneumonia can be divided into 2 categories, less than 5% honeycombing and those with more than 5% of honeycombing, reflecting the stage and severity of disease, and of course more than 5% honeycombing is the most severe. This occurs with lung architectural distortion as well as volume loss of the lobe, predominantly lower lobe. It can be either idiopathic or due to causes like connective tissue diseases, asbestos-related, fibrotic hypersensitivity pneumonitis, radiation, medication and drug toxicity, specifically amiodarone, and ANCA-associated vasculitis. Idiopathic pulmonary fibrosis, sometimes it's a separate entity, and some people consider it as the idiopathic usual interstitial pneumonia. This is our last case, a 66-year-old male patient with mesenteric vascular occlusion and complaining with hemopsis. The patient was on anticoagulant. Some axial lung window settings. And this is the coronary formatted images. We can see bilateral scattered areas of ground glassing. And in the view of the patient clinical history of hemopsis and the mesenteric vascular occlusion, alveolar hemorrhage is to be considered. The causes include pulmonary vasculitis, certain connective tissue diseases of the alveolar hemorrhage, and in our case, medication, excessive antiplatelet, and coagulation disorders, as well as inhaled toxins. Imaging varies from ground glassing opacities to predominant consolidation and is generated due to subtotal filling of the alveoli with blood. And the specific sign is the dark bronchus sign, where we can see the segmental or subsegmental bronchus prominent against the ground glassing. This is some of the references for more readings, and thank you.
Thank you, Professor Rania. Thank you, Professor.